everyone. So today we will be talking about the cutaneous lymphoma. Now, firstly, we should be dealing about the primary cutaneous lymphoma. So, as you all know, you have blood stem cells. Then they are divided into the myeloid stem cells and the lymphoid stem cells. Myeloid stem cells are further divided into your red blood cells, platelets. Then you have myeloblast that further divides into your granulocytes. In granulocytes, you have your basophils, eosinophils, and the neutrophils. Now, this lymphoid stem cells is divided into the lymphoblast. You have two types of lymphoblast mainly the B lymphocytes and the T lymphocytes, as well as the natural killer cells. So, what is a primary cutaneous lymphoma? It is an accumulation of malignant lymphoid cells in the skin without the evidence of extracutaneous disease at the time of presentation. So, you don't have any extracutaneous manifestations apart from these. Now, cutaneous T cells and the natural killer T or T cells lymphoma. So you have mycosis fungoides and variants. Then you have the Sézary syndrome. Then you have the CD30 plus lymphoproliferative disorders like your primary cutaneous anaplastic large cells lymphoma. Then you have the primary cutaneous peripheral T cell lymphoma and primary cutaneous aggressive epidermotrophic CD8 plus T cells lymphoma. In the cutaneous B cells lymphoma, you mainly have the primary cutaneous marginal zone lymphoma. Then you have the follicle center lymphoma, diffuse large B cells lymphoma, and the diffuse large B cells lymphoma, other types. So if I talk about the incidence, then in the Western countries, the annual incidence ranges in about this much percentage. The cutaneous T cells lymphoma constitutes around 75 to 80% of all the cases.
Persistent plaques, nodules, or unusual skin lesions may be more than a dermatologic problem. Cutaneous lymphomas can mimic common skin disorders, making accurate clinical and pathological correlation essential.
Understanding cutaneous lymphomas and hematologic disorders helps clinicians recognize subtle clues and make better diagnostic decisions.
Drops of papular or the papulonecrotic or nodular lesions that develops ulcerated necrotic centers, and healing occurs slowly over 3 to 12 weeks with fine atrophic circular or varioliform scars. So histopath, you have the four subgroups. There is predominance of scattered, large and atypical CD30 cells, and in B you have the small atypical T lymphocytes with convoluted nuclei and the involvement of CD30. In C cells, you have the large clusters of CD30 cells, and in D1, you have the atypical CD30 cells. So see this that you are able to see. First one that you are able to see is your Reed-Sternberg cells. Okay, now this is your lymphomatoid papules and you are able to see. Differential diagnosis, again, you can make a folliculitis and the anthropoid bites. Now, C-ALCL, that is characterized by solitary or the locoregional occurrence of reddish to brown nodules with the tumors with frequency ulcerated. This is the primary cutaneous anaplastic large cells lymphoma that you are able to see in the figure. And this is the cohesive clusters of large anaplastic cells with pronounced eosinophilic nuclei. Subcutaneous panniculitis-like TCCL. So you have the cytotoxic T cells lymphoma that is characterized by the presence of primarily subcutaneous lobar infiltrates of small, medium size and the large pleomorphic T cells with an alpha or beta T cells. Phenotype in association with many macrophages. Treatment, initially you can give prednisolone to the patient.
Not every persistent erythematous patch or plaque is a simple inflammatory skin condition. Some may represent an underlying cutaneous lymphoma.
Folliculitis can mimic early cutaneous lymphoma, especially when lesions appear erythematous and persistent. But their follicular pattern and clinical behavior provide important clues.
Arthropod bites can also resemble lymphomatous lesions. Distribution, morphology, persistence, and clinical correlation are essential for reaching the right diagnosis.